Good afternoon, everyone, and welcome. We're glad you're here for today's webinar, Leading Infinitely, Building Teams, Trust, and Vision. I'm Greg Barry, Director of Communications in the Office of Alumni Affairs. A disclaimer, as with any virtual event, occasional technical hiccups may occur. If you experience any video or audio issues, simply click reconnect or refresh your screen to return to the presentation quickly. Before we dive in, we'd like to learn a little bit about you. Please take a moment to answer this quick poll. How would you know what? I misspelled your. How would your team best describe your leadership style today? Would they say coach, architect, problem solver, vision caster, or calm under pressure? Go ahead and make your selection. We'll take a look at the results in just a few moments. Just a heads up, we are recording today's webinar. Our live audience will get an email with the link once it's ready, most likely later on this afternoon. Today, we're excited to have Dr. Matthew Sherrer back with us. Dr. Sherrer is an associate professor in the Department of Anesthesiology and Perioperative Medicine at UAB. He earned his medical degree from the Heersink School of Medicine and completed his residency at the University of Tennessee. He's recognized as a leader in physician development, is a mentor, educator committed to advancing thoughtful and inclusive leadership. Today's webinar rounds out a four-part leadership series. Previously, we covered the following topics: the evolving leader, from authority to authenticity; the humble narcissist, leading with humility; and inclusive leadership, building cultures of belonging. You can check out all those replays by visiting alumni.uab.edu/videos. Now, for the results of that first poll, let me go ahead and call that up. End it. 41% of our audience believe their leadership style is problem solver. 32% say coach, 19% say calm under pressure. So we do want to do a follow-up question. Thank you so much for sharing those responses. So what phrase best captures infinite-minded leadership? Leave it better than you found it, play the long game, progress over perfection, or purpose before profit? Go ahead and make your selection. We will share those results in the chat for you when I close the poll. At this time, I'd like to turn things over to Dr. Sherrer. Thanks so much for coming back.
Greg, thanks for having me, man. Thank you to UAB Alumni Affairs. That was a tough question. Is there like a D all the, or E all the above?
E all the above? I wish.
D and C. Well, thank you for having me. As Greg said, my name is Matt Sherrer. I'm an anesthesiologist here at UAB, graduate of the UAB Heersink School of Medicine. Wear this badge very proudly, and I'm thankful to be here today. So before I get going, I need to use that button right there. There we go. I have no financial disclosures. I do have a disclaimer. This presentation is based on an article I wrote that earned me the right to give this disclaimer at the beginning of every presentation, and you'll see why as we go. I said some things in an article called The Infinite Game about my specialty of anesthesiology that were perhaps against political narratives, and have since been asked by the Political Society, which I am the president of, to make sure that whenever I give this talk, I do let it be known that these are my thoughts and not the thoughts of the Alabama State Society of Anesthesiologists. Again, I am the president of that organization. I do advocate for my specialty, both at the state and national level. However, some of the things that I say are a bit against those political narratives, and I respect my group tremendously. And so I always give that disclaimer at the beginning. Oops, I keep hitting my button. I need to hit that button. All right, what are we going to talk about today? What the heck is this guy talking about? Infinite leadership, leading infinitely. What does that mean? So I want to talk about finite and infinite games in the context of the current state of affairs in my world of anesthesiology. And I think as we go, I want you to kind of think about this in your world, whatever it may be, because I think that these principles are applicable across business, across healthcare, et cetera. What are the components of an infinite game mindset? Number one, advance a just cause. Number two, build trusting teams. Number three, study your worthy rival. Number four, prepare for existential flexibility. And finally, demonstrate the courage to lead. And then I want to talk about our UAB Anesthesia Care Team Optimization Committee, or ACTOC, which I believe serves as an example of a team operating under the infinite game mindset. So what am I talking about? What are we talking about when we say finite versus infinite games? In 1986, a gentleman named James Carse wrote a book called Finite and Infinite Games. And in it, he said this: there are at least two kinds of games. One could be called finite, the other infinite. A finite game is played to win, for the purpose of winning, and an infinite game is played for an entirely different reason, for the purpose of continuing the play. When I think of finite games, I think of sports. When I think of sports, I will go to the undisputed greatest play in sports ever in the history of the world, and I will accept no rebuttal to that, because this play, to me, is I say it today, what I said then is that I can't believe that just happened. Undergraduate degree from the University of Alabama, Roll Tide. There are probably some Georgia people on here, and you can send me your hate mail later. But this is a finite game, right? There is a clock. At the end of the game, we walk to midfield and shake hands and say, you won and you lost, right? It is played on the same field with rules. There's even referees to enforce the rules. But we know, why are we playing the game? To win. And at the end of it, we will walk away, the game will be over, and we will declare a winner and a loser. As the great Herm Edwards says, you play a finite game to win the game. You play to win the game. But there are other games in life that are not finite, and we run into trouble when we use a finite mindset in an infinite game, or an infinite mindset in a finite game. But we need to understand the game that we're in and what mindset we need to use in that game. For example, marriage. How in the world do I win marriage? How do I defeat my spouse and declare myself the winner? Anytime I've tried that, it hadn't gone well. If somebody has figured that out, let me know. I would argue that you're probably no longer married, or I'll just leave it at that. But how do you win marriage? How do you win career? How do you get to the end of your career and go, I won? And does everybody think you won? What does that mean? Is it a title? Is it money? Is it a company watch and a trip to Hawaii? What does it mean to win career? What does it mean to win at life? How do you get to the end and go, all right, I won, time's out, game over? What does that mean? Is it how much money you leave behind? Is it your legacy? What does that mean to people? And does everybody agree upon the same criteria for winning and losing? And so in 2019, the year that I came back here to UAB to be on faculty at UAB, a book was released that I would say at this point in time in my career has changed my life. I read it during a really hard time when there was conflict between our anesthesiologists and our nurse anesthetists. My state society political role threw me right into the middle of that. There's a period of time when I was considered an enemy to CRNAs across the state of Alabama and beyond. I have talked to the president of the AANA, the American Association of Nurse Anesthetists, at that time. And he's become a friend of mine. And he said, oh, yeah, we knew about you, buddy. We had heard about you. So at that time, I read a book called The Infinite Game. And it really changed the way I think about the business of anesthesiology. As you can see, I run a workshop series at UAB called Lead Infinitely. This is the namesake for that. It was based off this book and an article that I wrote entitled The Infinite Game that I will tell you guys about in just a second. But in that book in 2019, Simon Sinek said, carrying on James Carse's work and applying it to business, said in a finite game, the game ends when the time is up. The players live on to play another day, unless it was a duel and you're Aaron Burr and Alexander Hamilton, then somebody doesn't live on. But in an infinite game, it's completely different. It's the opposite, right? It is the game that lives on, and it is the players whose time runs out. And he said that marriage, career, life are all examples of infinite games, as is the game of business. And the book is his case for that. He tells us, look, there are three factors in deciding how we lead in our businesses. We don't get to choose whether a game is finite or infinite. We get to choose whether or not we join. But this is the key. When we join, we get to choose whether we want to play with a finite or an infinite mindset. And the problem occurs is when we play with the wrong mindset in the wrong game. A finite game mindset in the infinite game of business results in a steady decline of trust, cooperation, and innovation, all of which make it more difficult to thrive in this rapidly changing, volatile, uncertain, chaotic, and ambiguous world that we live in. However, the leader with an infinite game mindset doesn't fixate on what or how the competition is doing. They focus instead on themselves. How do we build an organization that is strong and healthy enough to stay in the game for decades to come, long after I have left the game as a leader? He tells a story of Microsoft and Apple having just done a workshop series or worked with the leadership at Apple and seeing how they were relentlessly pursuing bringing technology to the common man. That was their vision, and they pursued that unwaveringly. Microsoft, to the other end, a little bit different. Sinek says that when he dealt with Microsoft, their purpose was to try and defeat Apple, and that every executive and employee that he dealt with in every single meeting's purpose was to defeat Apple. He tells the story of getting in a cab with an Apple executive, tells you how long it was because he got in a cab, and sharing the cab with this Apple executive, and taking the opportunity to say, I was at Microsoft recently and they gave me this new Zune, and it's really fantastic. In fact, it's better than your Apple iPod. And he said the Apple executive took it and looked at it, studied it, and handed it back to him and said, "I'm sure it is." And that was the end of the conversation, because the Apple executive wasn't focused on what the Microsoft executive was doing or what that company was doing. He was focused on what his team was doing. I remember telling my kids many, many times, I don't care what they did. I care what you did. I care how you respond. So focusing on what we do, not on what they do. And as I said, I took this and I wrote an article, and it was eventually published in Anesthesia and Analgesia. I will tell you, it was angrily rejected numerous times, angrily, for violating political narratives and for suggesting the idea of collaborating with perceived competitors. It did make its way out there, and to say that it has changed my life, my career, is true. It got a lot of press in the, or not press, it's got a lot of publicity in the anesthesiology world. It's been talked about at national meetings, to a meeting, and someone presented it to me, which was crazy. It is the namesake for the Lead Infinitely workshop, but all I did was simply apply Simon Sinek's principles to the business of anesthesiology and suggested, is there a way to look at what we've been doing differently? And I'll walk you through that. So to kind of set the tone of what I'm talking about, and again, I want to set the tone in my world, which is anesthesiology. As you listen, I want to think about, I want you to think about your business world, your climate, wherever it is that you work, because these principles are universal across business. So in my world in anesthesiology, there was a report back in 2016, 17 called Reforming America's Healthcare System Through Choice and Competition. This was a bipartisan effort from the Department of Treasury, Health and Human Services, and Labor, in a letter to the president about what the topic says. It's about reforming America's healthcare system. These comments were made, and this is available on hhs.gov. It said on page 33 that APRNs, Advanced Practice Registered Nurses, that would be nurse practitioners, nurse anesthetists, physician's assistants, etc. APRN scope of practice varies widely for reasons that are not related to their ability, education, or training or safety concerns, but to what? To politics, political decisions of the states in which they work. Furthermore, states should consider changing those scope of practice statutes to allow all healthcare providers to practice at the, if you're in healthcare, you've heard this, top of their license. Furthermore, states should consider eliminating altogether requirements for rigid collaborative practice and supervision agreements between physicians and their care centers that are not justified by legitimate health and safety concerns. So it makes sense then that the American Association of Nurse Anesthetists, having existed that way for decades, would change its name to the American Association of Nurse Anesthesiology, award doctorates. So they are doctors of anesthesiology. Well, hang on, I'm an anesthesiologist. I thought I was a doctor of anesthesiology. And as you can see, the political rhetoric has gotten pretty fierce. I would argue that it is black and white position statements fighting against one another. CRNAs say, we are the answer. We don't need you anesthesiologists. The anesthesiologists fight back and say, hang on a second. You say you're a nurse anesthesiologist. That's just wrong. We're the answer. No, you're not. You're wrong. And so politics in our world can get pretty nasty. And I've witnessed this here at this institution. I've witnessed it at others as well. It's not just the American Association of Nurse Anesthesiology. Did you know that the American Academy of Physician Assistants, celebrating a 2021 Utah law allowing for full practice authority for physician's assistants, has changed its name to the American Academy of Physician Associates, wishing to distance itself from the idea that they simply assist physicians? In our world, there is a new entrant into the playing field. It's called an anesthesiologist assistant. It is the PA equivalent to nurse practitioner in anesthesia. AA, anesthesiologist assistant, a direct competitor in the marketplace to nurse anesthetists. It's not hard to go find articles on advanced practice providers more and more leading healthcare teams. I'll read you the first bullet point there. Changes in state laws that grant full practice authority to advanced practice providers and physician shortages, not enough of us, are opening the door for care teams led by nurse practitioners and physicians assistants. It's a pretty competitive world that we're in. Not only is the ASA, my governing body, the American Society of Anesthesiologists, pushing back on this, but so is the larger American Medical Association. The American Medical Association has vowed to fight, to combat, literally battle language in its verbiage, to combat medical title misappropriation. Just a few years ago in Georgia, one state away, a law was passed banning medical title misappropriation, prohibiting non-physicians from using the title doctor in clinical settings. It requires those advanced practice nurses and PAs with doctorates to specify that they are not medical doctors. And so while I would argue that most people would say that American politics at large is pretty nasty, it can get pretty ugly, we're pretty polarized, and we're throwing things across party lines at one another. I realize now how old this slide is. Good grief, how many pictures could I have added to this between now and the time that I first put this presentation together? I would argue that we have to put ourselves in there in medicine, in healthcare. We can get pretty wrapped up in professional politics as well. And as I have lived and I have seen in multiple specialties in the State House in Montgomery, it can get pretty contentious. Now, guys, with those people who you are competing against on the battlefield of the State House yesterday, now walk into the operating room and go take care of the sickest patients in the Southeast in a team environment. That's hard to do. How do we reconcile that? And that's a lot of what I talk about in the Lead Infinitely workshop series. So how do I apply that then in my world? How can I encourage my specialty to look at the game of anesthesiology, of anesthesia care delivery differently? How can we look at that differently? And instead get out of this us against them mindset into a how can we build something sustainable that will outlive us all? After I'm out of the game, it will continue to thrive. And that's the concept of the infinite game in anesthesiology. Again, you can see the rules of the infinite and finite games there. Finite game is known players, fixed rules, a defined beginning, middle, and end. The game ends and we declare a winner and a loser, and we play to win the game. An infinite game is different. It's played by known and unknown players. There's no exact agreed upon rules. There's no time horizon. We don't know when it's going to end. There's no such thing as winning and losing, and the objective is entirely different. The objective is to keep playing the game. And again, where we get into trouble is when we are playing with the wrong mindset in the game that we're in. So we kind of stated the case in this article, and again, angrily rejected numerous times before finally being accepted and published. And so this is the current state of affairs in my world. Again, apply this in your mind as you're thinking to what's happening in your world. How can I apply this in whatever it is that you do in your business? So there is a shortage of both anesthesiologists and nurse anesthetists. There's not nearly enough of any of us. There is a workforce shortage. It is all you hear about at meetings. I had a friend, Rick Dutton, say voluntary unemployment in anesthesia is effectively zero. If you want to work, you can work. Plenty of jobs out there. We need more people, and we need them badly. So there's a shortage of both anesthesiologists and nurse anesthetists. It begs the question, then, why are we fighting over turf? Why are we fighting to own the entire pie when we can't eat our own slice? There's increasing burnout across the board in healthcare providers. What's that all about? Is it because we have a contentious and uncivil work environment? Is it because of our workforce shortages and we're working extended hours? I would argue yes. And then furthermore, if we're really honest with ourselves, can the membership of the ASA or the AANA on its own really meet the growing anesthetic demands in the United States? When I was a resident, all of our work was done in the operating room. Now, over half of our work is done outside of the operating room. We call it NORA. There's been an explosion of procedural sites around the hospital, as other practitioners have begun doing more interventional things, and so our demand has exploded outside of the operating room. Can we really meet this growing demand with a diminishing workforce? And furthermore, hey guys, if the PAs change their name from assistants to associates and have lobbied for an independent practice, don't we think that the AAs that we push so hard to compete against these CRNAs, don't we think they're ultimately going to do the same thing? Are they not going to lobby for independent practice one day as well? Just to kind of set the scene more, intention to leave in my specialty is through the roof. We are the far end of this graph, the clear outlier on intention to leave the specialty. This is multifactorial, and I can't point to one thing or another. But again, our workforce shortages are not fixing themselves anytime soon. If you look at well-being, burnout in our world, that whole intention to leave thing that I just mentioned, what contributes to that? Well, it's burnout, it's lack of professional fulfillment. And on the converse of that, instead of having supportive environments, which have been associated with retention, we have uncivil environments often. That's something that we have dealt with certainly here in anesthesiology. So are we compounding our problem by the way that we treat each other at work? My specialty has a real problem right now. We are unfortunately number one again for HID. That's harassment, incivility, and disrespect. That is troubling. I do not fully understand this. There are committees delving into this right now, but it is something that we absolutely have to overcome as a specialty. I do think professional politics plays into that. If you look at our business model, I would argue that it's unsustainable. Shameless plug for the Fresh Flow podcast here. It's a podcast that I host here at UAB. It is an anesthesia-centric podcast, but we do talk about leadership topics as well. And we had a gentleman named Dr. Bob Stiefel on. Dr. Stiefel is a partner and principal in Enhanced Healthcare Consulting. They do anesthesia contracting around the country. My specialty is a subsidy-driven specialty. Our collections do not meet our costs, and so therefore we do require subsidies at our hospitals pretty much universally. And those stipends are increasing. If you look at the dollar amounts of subsidies over the last 3-year cycle, a typical anesthesia contract cycle, they have gone up by tens of millions of dollars. At that point in time, when we interviewed Dr. Stiefel on the podcast, he gave us the numbers of 50 to 630% increase over the 5-year cycle. He then came to a meeting, the AACD Perioperative Summit last year, and bumped that number up to over 1,050%. He's a friend of mine. I texted him this morning. He sent me new data. It's now over 1,500% increase in one single 3-year typical anesthesia cycle. So subsidies are going through the roof. Here's an example of that his partner, Howard Greenfield, another principal in Enhanced Healthcare Consulting, published in Anesthesiology News. These are actual subsidy increases from one 3-year contract to the next in their book of business. And you can see that the numbers are getting astronomical. I remember Dr. Stiefel telling the listeners at the AACD Summit, be prepared when you give the ask for your anesthesia subsidy. Be prepared for your CEO to fall out of their seat. It is sometimes larger than the bottom line for the hospital system. I would argue that that's an unsustainable model. Certainly, do we need to maximize revenue for our people? Yes. And we also have to build a sustainable future. So, according to Cynic, related to what I just showed you, players or participants drop out of the game, whatever the game is, when their resources or their will is exhausted. And I would argue from what I've just presented that with the current shortage of anesthesiologists and nurse anesthetists and the increasing rates of burnout among healthcare providers, we appear to be running out of both resources and will. There's 2 ways you can look at the recent windfall in financial support. You can celebrate it and say, great, we're going to be okay for the next 3 years, or you can look at it as a respite to examine our specialty, to examine our business model, and to think about paths forward in the future. And so we did that, and we applied the infinite game mindset to anesthesiology. There are 5 components to an infinite game mindset. Number 1 is advancing a just cause. Let's start there. We're going to go through all of these, and I want to present what we presented in our article. Advance a just cause in anesthesia. What does that mean? If you know Simon Sinek, you know that he's the know your why guy. Not your what, not your how, but your why. Why do you show up and do what you do? It's your purpose. It's your North Star. And for us, we named our new fictitious anesthesia entity, Infinite Anesthesia. And we said, look, this is our just cause. First of all, what is a just cause? What are the criteria for that? Well, it has to be for something, not against something else. No, we are for something. We're not against CRNAs. We're not against anesthesiologists. We are for this, and I'll give you that. It has to be inclusive, and it has to be open to all members of your team. It has to benefit others. It has to be service-oriented. It has to be resilient, able to endure change. Many of you have likely heard the only constant is change. And it has to be idealistic. It has to be big, bold, and forever beyond reach. When I think of this in my world, I think of the Anesthesia Patient Safety Foundation, whose vision is that no patient be harmed by anesthesia care. Will we ever get to that point? Probably not. However, we're doing pretty dang good. We've developed essentially 6 Sigma level safety in the perioperative space. And so our just cause, as this newly created entity that we wanted to kind of introduce as a thought experiment, we said the just cause pursued by Infinite Anesthesia is the creation of a mutually supportive workspace that maximizes patient care with every encounter in a way that appreciates every team member. And we said to do that, we're going to have to do a few things. We're going to have to move beyond political narratives. I encourage people in my workshop series that you should advocate. I should advocate. Nurse anesthetists should advocate, nurses, etc. We should all advocate. However, when we show up at work, can we build a collaborative conflict culture? Again, part of another workshop that I do. Can we agree that we are here? We put on the UAB medicine jersey. We are all in this together to provide outstanding patient care every single time. So can we move beyond those political narratives when we come into the operating room? We're going to actually form an interprofessional leadership group. We're going to have a leadership group that has what we call cross-cutting structures. We're going to include those from all ranks in the hierarchy. And that group is going to help us focus on all stakeholders thriving, everyone on our team thriving, realizing that leadership can mean telling people what to do, and it can mean empowering people on our team to work at their level best all the time. What are the requisite leadership qualities for this group? Well, number 1 is civility. One of my workshops is called Leading with Civility. Another one is inquiry and openness to new ideas, with a purpose of creating an inclusive, respectful, and fulfilling work environment, and understanding that such an environment is critical to well-being, resiliency, and job satisfaction, again, in the era of burnout and intention to leave. The idea of civility is a big one. It is a workshop that I do. I have an entire workshop and PowerPoint presentation just like this dedicated to civility in the workplace and in healthcare. I want to point everyone to my friend Chris Turner. Chris runs a platform called Civility Saves Lives. Type it in right now, civilitysaveslives.com. Chris is a UK emergency physician. He goes all across the UK and Europe talking about incivility in healthcare and what it means to the people we work with and the patients that we are privileged to care for. Tons of resources there. Most of my incivility talk came from my friend Chris's resources on his website. I had the pleasure of writing an article with Brooke Vining, one of my CRNA colleagues, about this was a different one. We wrote one about care teams, but writing an article about incivility in healthcare, what it means to our patients, and are we putting our patients at risk through uncivil behaviors. You can see here, Chris has been on the Fresh Flow podcast as well, in addition to Dr. Stiefel. I think it's the best episode we ever did, not because of me, not because of my co-host Mitchell, but because of Chris. He's a great guy. He is a crusader for civility in healthcare. Please go check that one out, and then check out his platform, civilitysaveslives.com. And I'll also mention how important inquiry is, curiosity, developing this sense of curiosity and actually caring about what everybody on our team brings to the table. Another one of my talks is called Leading Collectively. It's about collective intelligence and teaming. Teaming is a concept introduced by Amy Edmondson. She brings up this idea of psychological safety, creating an environment where people feel safe to bring relevant information to the forefront. And doing so requires leaders who have a sense of curiosity and who invite all of those different perspectives from all teammates. I love her quote, and I use it frequently. Teaming leaders aim to engage teammates on a collaborative learning journey. I'm curious, what can you teach me? What do you bring to the table? And what can we all learn together on this collaborative learning journey? So that was advancing a just cause. The next thing we do is called building trusting teams. And so in Infinite Anesthesia, we want to do that by acknowledging that professional politics can create disrespectful interactions. It's no wonder I got pushback on this article, right? It's no wonder I have to put a disclaimer at the front of this presentation. Professional politics can create disrespectful interactions. They can break trust, and they can weaken psychological safety. I have seen that, and I can attest to it in the perioperative space. We're going to address those issues intentionally, humbly, and civilly by bringing in outside experts, facilitators, to mediate our discussions and to facilitate respectful dialogue until it becomes self-sustaining. This is directly from our work in ACTOC, the Anesthesia Care Team Optimization Committee. We were so broken, so emotional, so fragmented at the beginning of our journey that I do not think we would be where we are today out talking about our journey had we not had a skilled facilitator. We had a skilled facilitator, psychologist, Dr. Martha Ann Rich here locally, who guided us masterfully through our process. And I do not think we would have succeeded without her. But we are now at that place where we are sustaining the dialogue without her. I love the quote from Simon Sinek from The Infinite Game. If you don't have trusting teams, what you have instead is a group of people who show up to work every single day lying, hiding, and faking. And I'm positive that resonated with somebody here today. I can think back to my short white coat days as a medical student, certain rotations with a kind of dictatorial leadership style where you've seen people get chastised for saying things, for being rejected and punished for saying certain things, and being like, you know what, I'm just going to be quiet today. I'm just going to show up and I'm not going to say anything. I'm just going to get my B on this rotation and get out. And I can admit that I have showed up to work lying, hiding, and faking in my career. So to that end, as we build trusting teams, what we're going to do in Infinite Anesthesia is we're going to design and implement an interprofessional education curriculum to enhance the knowledge of teamwork and leadership. If I were to do that at UAB, I would probably call it something like Lead Infinitely. Basically, I've said, if you're going to go out and say something like this in a very public article, you better be willing to do it. And that's exactly what Lead Infinitely is for us here at UAB. And now through my role in faculty affairs, I get to now take this all across the hospital system, far beyond the walls of the perioperative space, into all corners of this hospital system. And it's been an absolute blast thus far. We're going to build upon our collaborative culture that we've built to advance models of care that are new and novel and suitable to each location. We're going to use our enhanced communication because of the trust that we've built to move beyond traditional supervisory roles. That's a big one. If you say that 1 to 4 is an arbitrary number, that's the 1 anesthesiologist to 4 anesthetist ratio that was arbitrarily set in 1983, and that there are places where we can do it differently. You can expect pushback because you're challenging a payment model. But if we build trust, I believe that we can begin to address our anesthesia workforce shortage by changing the models. And we're going to ensure patient safety in those new models and satisfaction through pre-procedural triage protocols, remote supervision using technology, being available for rescue, but not necessarily having our hands on the propofol syringe ourselves every time, and by supporting continued technological advancement. So that's building trusting teams. The next is study your worthy rival. Remember the Microsoft and the Apple executive. The Apple executive being focused on what he is doing, his purpose, his North Star, his just cause. Studying his worthy rival, the Microsoft Zune, but not focusing on defeating them, allowing it to make him raise his game, right? If they're doing better and they're producing great products, cool. That means we got to step up our game too. It makes us better. So as we study our worthy rival, in my world, what that means is that as an anesthesiologist, I'm going to see CRNAs not as my rival, but as a fellow player. And we do have some rivalries, some worthy rivals as well. We're going to, or some enemies as well. We're going to compete against the status quo of bipartisan rivalry. We're going to compete against disease and illness, and we're going to aim to defeat that, not one another. I got to speak to the graduating medical students the other day and told them, hey, if I can give you one piece of advice, the people in the hospital are not your enemy. They are there to take care of patients as well. We have a very real enemy. It's called disease and illness, and it's complex and it's challenging. Let's focus our efforts there. As we study our worthy rival, by seeing our CRNA colleagues, nursing colleagues, et cetera, as fellow players, we can overcome microaggressions. We can alleviate stress. We can minimize burnout by rising above the political animus, and we can jointly build toward a better future state. That was extremely challenging to get that accepted in the anesthesiology world. We have the opportunity to advance this model now, because as I said, every hospital, every surgery center would like more anesthetizing locations. If we gave UAB 20 new anesthetizing locations tomorrow, they would take it and they would fill those rooms up in about an hour. Every anesthesia practice is hiring. Why are we competing against one another when there is more work than we can possibly do? Voluntary unemployment in anesthesia is effectively zero. Again, a quote from my friend Rick Dutton. And so to provide the most service to our stakeholders, our patients, our surgical colleagues, our proceduralists, our administrators, the ones footing the bill for those increasing subsidies, we must use our limited resources to the fullest. And to that end, promoting the excellence and full practice, full scope of practice of all anesthesia professionals will help us avoid disintermediation. That was a polarizing thing to say. And again, I do think this is something that we have to consider. If we are not making those decisions and we are allowing politicians or payers to determine where we can do certain levels of care, I would argue that we as the healthcare professionals are abdicating our responsibility to our patients, because we know where we can change the way things are done. If we don't take ownership of the demand for anesthesia problem ourselves, the solution will be created without us. And rather than accepting whatever change is forced upon us, we, Infinite Anesthesia, this new entity, we're going to collaboratively lead the needed change. Next, we've talked about advancing a just cause. We've talked about building trusting teams. We've talked about studying our worthy rivals. The next one is preparing for existential flexibility. What does that mean? Existential flexibility is the ability to initiate an extreme disruption to a strategic course to more effectively advance our just cause. When I think about this, I think about CVS Health changing its name from CVS to CVS Health because we want to advance the health of our customers. Well, then can you sell cigarettes? No, actually we can't. We actually can't sell cigarettes. It's a huge source of revenue for us. But if we're going to advance our just cause, we may take a dip initially, but it's going to resonate with our customers and it's going to help us in the long run. And that's exactly what happened. Existential flexibility is responsive and forward thinking. It is not defensive and reactive. That's kind of what we do in professional politics. We wait for a bill to be introduced in the State House, and then we react and go fight it. That is not what preparing for existential flexibility is. Existential flexibility, the response is to be forward thinking rather than defensive and reactive. And so we made this comment: the growth of the CRNA and the certified anesthesiologist assistant should not be viewed as a threat by anesthesiologists, but rather through the infinite game lens as a celebration that our specialty has reached such a level of safety that we now have a unique opportunity to advance new, innovative, and disruptive models of care that deliver our equally superb outcomes, but in a creative, patient-centric, and more cost-effective, cost-efficient manner. I've written about all kinds of potential technological advancements, all kinds of innovations. I want to give credit to my friend Nirav Kamdar, who wrote a beautiful article about implementing a telemedicine preoperative evaluation clinic, managing complex patients virtually, reaching them in their home where they are rather than making them come to us. It can be done, and it can be done well. Dan Sessler, the most published anesthesiologist in the history of the world, has given a Rovenstein lecture, which is kind of the keynote at the ASA meeting, and told our specialty, hey, there's a gathering storm. We're wasting our time by fighting against our nurse anesthetists. We're not going to win that battle. Nobody's going to win that battle. And in fact, it's not the battle to be fought. The battle to be fought is against our workforce shortages, against the number 3 leading killer in the United States, which is the first 30 days after surgery. We've been focused so intensely on the intraoperative period and have achieved 6 Sigma level safety there. we have not seen that the first 30 days after surgery is the third leading killer in the United States. How can we extend our model into that period and begin to now fix that problem as well? I wrote another article called The Icarus Paradox and get listed numerous opportunities for innovation. And I won't bore you with those innovations, but I will say that number 11 there got me a fair amount of heat to consider working with, not against, our nurse anesthesia colleagues to embrace the anesthesia care team, rethinking the model in a way that promotes outstanding patient care, while also ensuring the wellness, retention, fulfillment, and sustainability for all team members. When you talk about innovation, I'd be remiss if I didn't mention Jeremy Utley and the idea of idea flow. In that book, he said that the riskiest move is no move at all, because if we are too scared to leap to the next patch of ice, then the one that we are standing on will end up melting anyway. The only constant is change. I had the privilege of writing an article on idea flow in anesthesiology with Jeremy Utley. Again, we put numerous innovation ideas to paper, collaborating with perceived competitors being one of them, new financial models, explore new branches for the specialty. Again, that post-operative care period, again, post-operative care, the first 30 days being the third leading cause of death in the United States. I had my friend Rick Dutton on the show. I mentioned him earlier. He's the one that used the big word disintermediation. But he came on our podcast. Rick started the Anesthesia Quality Institute. He is the Chief Quality Officer for USAP, the largest private practice anesthesia group in the country. And he came on the podcast and said, it's time for anesthesiology to get over its bad self. It's time for us to allow other people to use some of our medications and to set up systems to allow them to succeed, to set up guidelines, boundaries, rescue capabilities, but to let other people begin to do some of the things that we do so we can focus on the things, deploy our people in a more efficient way. Also a controversial statement. I've written on sedationists. That's exactly that. Can we begin to move away from this idea of just using anesthesia in the name, be it an anesthesiologist, anesthetist, or whatever, and let's acknowledge the continuum of sedation, and that sedation is its own thing. Should we have people just to do that? Should we not train nurses to use some of our wonderful and safe medications, our wonderful and safe monitors, our wonderful and safe airway maneuvers and devices, and begin to kind of scale our operation, providing rescue, providing guidelines, providing boundaries, but actually taking our hands off of the propofol syringe and handing it to someone else? Again, controversial to write and to put into print. And if you're going to write stuff like that, you better have the next one down, which is to demonstrate the courage to lead. Rather than viewing the disparate opinions on the future of anesthesia care as a friction point, which it is, we can embrace the perspective that these varying viewpoints provide balance and hence advantage in our strategic thinking. I get pushback on this kind of stuff all the time, and it's okay. I acknowledge that I am a forward-thinking, future-oriented guy. I love talking about how we can do things in the future. How do we scale our model? That gets me excited. It fires me up. But I acknowledge that if left to my own, I will implement far-fetched ideas that can't be implemented. I need more present-focused people, or past-focused, who understand the past, to tether me, to hold me back, to keep me from having runaway ideas. And so, can we discuss these different opinions in a mutually respectful way? I would argue that if we can, then we have strategic advantage because of the balance that it provides our thinking. And then we said in the article, in dynamic environments like the surgical space, leaders with a future-oriented temporal focus need the counterbalance of those within their organizations who focus more on present and past. And if we can simultaneously concentrate on those paradoxical temporal foci, then we can prevent our leaders, like Matt, who I would, if not tethered, I would run away and implement ideas that can't be sustained. We can prevent leaders from developing far-fetched ideas that cannot be implemented, or the contrary, easy to implement ideas that lack novelty, providing balance in our thinking. Because why? Because we can both look at something, see things completely differently, and both be right. As I kind of close here, half of you guys are looking at the young lady, old lady illusion there. Half of you see a young lady looking off into the distance with her hair flowing behind her, wearing a bonnet. Half of you look at it and see a tired, older lady looking to the left of the screen with a wart on her nose. And I would tell you that you're both exactly right. You both are exactly right in seeing what you see. F. Scott Fitzgerald said years ago, the test of a first-rate intelligence is the ability to hold two opposed ideas in the mind at the same time and still retain the ability to function. Can we have balance in our thinking and in our teams? And now I want to take a moment to talk about the team that I've actually been describing along the way. At UAB, that's our Anesthesia Care Team Optimization Committee. I'm going to finish up the next few minutes here and leave time for discussion. We went through really, really hard times. Professional politics wrecked our teams. We realized that we were a threat to patient safety because of the animosity between our nurse anesthetists and anesthesiologists. Our communication was atrocious. We were in a bad place. We are now 7 years on the other side of this kind of reconciliation journey that we've been on. And we now get to go out and talk about this kind of stuff because I do believe that we have significantly changed our culture. You can see the mission that we wrote there: optimize the perioperative care of our patients by building and promoting an inclusive, respectful, and fulfilling anesthesia care team, just like we said we were going to do in the Infinite Game article. Again, I won't bore you with the details of this, but on the left, you're looking at a team of people who absolutely would not even look at each other. I distinctly recall CRNAs seeing me coming down the hallway and turning and going the other way. We were not communicating during cases at all. And this is a team that now has joint journal clubs that you see here, well attended, I would say pretty much universally loved in our department. We still do these to this day. We bring anesthesiologists, nurse anesthetists, residents, student nurse anesthetists into this, go over a few articles, meet, have a tasty beverage, break bread. It still works. It's worked for centuries. It still works today. Again, more pictures of our joint journal club. Brooke Vining, who I mentioned, has been the CRNA leader of that ACTOC team with me. We co-lead, an anesthesiologist and a CRNA co-leading this culture effort. And we onboard CRNAs when they come on board. We sit before them and we share our story and we share our mission, our values, our vision, and tell this story and don't shy away from it. We have routine team meals where we come together. We'll buy your lunch, but you don't get to retreat to your office. You got to actually sit there in the room and eat in the room with the people on your team who you might not otherwise get to know, break bread, get to know one another. This is a word cloud from a recent survey that we did. And again, a team of people who would not even look at each other, to be on the other side of that now and see this word cloud to me is incredibly rewarding. Shameless plug for Jean Ann Larson, my friend, and the Leadership Development Office, the LDO. They have numerous offerings. If you need to do something about your team here at UAB and healthcare, need to bring your team together to work on your teamwork and your leadership, there are numerous offerings. The one that I get to help with is the High Performing Care Collaborative. And then my effort over the last year and a half has been Lead Infinitely. It is a workshop series that I developed initially for perioperative teams to come together. Here's some information about these topics that you can see with this one, Lead Infinitely, Leading Infinitely, being the final kind of summary workshop in that series. And we bring interprofessional teams together and we have them sit together and wrestle over some of these things. They talk about the hard things that we're talking about right now, and I give leading questions to facilitate that discussion. So in wrapping up, know the game that you're in, right? Know the game that you're in and what mindset you need to be using in that game. A finite game is to be won, but there is no winning in an infinite game. The infinite game lives on. Being the best, defeating those that we work with is a fool's errand because we realize we have first-rate intelligence. We realize that multiple players can do well at the same time. We've talked about advancing a just cause, building trusting teams, studying our worthy rivals, preparing for existential flexibility, and then displaying the courage to lead. When we play in an infinite game with a finite mindset, we damage trust, we damage cooperation, and we damage innovation. As leaders, can we have a paradoxical focus on different temporal foci to provide balance to our thinking? And again, I will say this, we have an enemy in the hospital, we have an enemy in healthcare, and it's not each other. It's disease and illness. Let's take on that. Let's fight that battle instead of fighting one another. And I'll leave you with a quote from the Infinite Game from Simon Sinek. Pure pragmatism can't imagine a bold future. Pure idealism can't get anything done. It's when those two cooperate that magic happens. Y'all have been great. I appreciate it. I am happy to take a few moments and answer any questions that you may have in the time that we have left. Thanks, Greg.
Thank you so much. And I will say this when it comes to Matt, I don't think there's very many people more passionate about particular topics than you are. So thank you so much for having the passion.
Thank you.
And if you do have a question, we do have a few minutes to drop those in the chat. I'll go ahead and start. What mindset shift do leaders most often struggle with when they first encounter the infinite mindset idea?
Well, gosh, all of these. What I was talking about in my world was countercultural. This had been the norm for many, many years. I think the biggest one in my world to overcome was that rivalry, right? Studying your worthy rival. We're not here to defeat them. If their game rises, great. That means that we need to raise our game too. And when I tell this story, I mentioned I told my kids they get tired of hearing it. I don't care what they do. I care what you did. And I use a football example. I remember a game. And if you're a football fan, you've seen this happen where there's a fight on the field. Somebody punches somebody first, and who gets the flag thrown on them and who gets the penalty? The guy who retaliates, right? And that happened in an Alabama game. And this player is running off the field because he just got a personal foul, 15-yard penalty. And Nick Saban is all up in his grill, man. He's up in his face. And they zoom in close enough that you can read the lips. And the one guy goes, well, he pushed me first. And Nick Saban looks at him, and I go back to my kids all the time, and says, I don't give a something what he did. I care about what you did. And that's what I'm talking about. Like, let's focus on ourselves. Let's raise our own game. Let's realize there's enough work for everybody to do. We're not competing against them, right? We're not trying to defeat them. If their game rises, so should ours.
So if attendees walk away with, and apply just one principle to everything that you talked about, and they walk away from this session over the next 30 days, what's that one principle you want to
So I'll let Simon Sinek have the first one, which is know your why, advance a just cause. That's his platform. That's his thing. The one that I've really taken and run with is building trusting teams. And it's so hard. It's so incredibly hard in our world to actually build trusting teams. And what I'll say is that it doesn't just happen. Teamwork can be developed. It can be cultivated. Collaboration can be developed and cultivated. It doesn't just happen. I've got a book over here called In Search of Synergy in Small Group Performance. This is a fantastic book. I got it at the beginning of this journey. I did not have that ready. It just happened. I looked over and it was sitting there. At the beginning of this journey, I got this book and I thought this is going to be the answer. This is what's going to tell me how to fix the anesthesia care team. I read through it. It is heavy. It is how many pages? It looks like it's at least 400 something pages, and it's study after study after study. It's thick, it's dense. And at the end of it, I basically said, synergy in our small groups. It's possible. It can be done. We should do it. We owe it to our patients. In my world, we owe them the best care we can possibly provide. But it's hard. It is difficult. It takes intentionality. And it's why I go out and do what I do. It's why the Lead Infinitely Workshop series came about. It's why I have the passion that I have, because I've seen communication and teamwork impact our patient care. And I think we owe our patients far better than that.
Dr. Sherrer, thanks so much for coming back. You're welcome back anytime, my friend.
Thanks, brother. I appreciate it, man. Thank you for having me, Greg. As you saw, I've got 5-6 of these topics, and they're ready to go. So you can tell me I want you to do another one at 1:00, and I'll be ready to go. I'll fire one off. So appreciate it, man. Thank you for having me.
Fantastic. And just a quick note for today's audience, this webinar was recorded. Once it's uploaded onto our website, you'll get an email with a link so you can revisit the session or share it with others. As for the next 4 webinars on tap for you, join us for the following. On May 13th, join us for Fueling Discovery, Libraries at the Heart of Learning. We're going to take a look at how libraries have transformed into dynamic, tech-driven institutions. On May 21st, come back for Stronger This Summer, Nutrition, Exercise, and Safety. During this one, we're going to get practical tips for eating smart, moving safely, and avoiding heat-related injuries. On May 28th, we'll host Intermittent Fasting and Meal Timing. Does when you eat matter? This webinar will highlight how meal timing can influence overall health and daily well-being. And on June 9th, make sure you're getting the most out of your legacy during Your Estate, Your Legacy. Key decisions that matter. You can register for all these and more by visiting alumni.uab.edu/events. As we wrap up, we'd love to hear from you. Your feedback helps us improve and shape future webinar topics. Just scan the QR code on your screen to access a brief survey and share your thoughts. Once again, thanks so much for joining us. And as always, go Blazers.